I will also tell you my first, because it's a bit of a combination between Steve and Deepak's, which is about 2 weeks ago, my husband and I left my child, who has the genetic epilepsy, for the first time ever, for 3 nights. And we did that so we could go to Tasmania and do some hiking and have some time by ourselves. And it was awesome, so I'd recommend it. But I did have to write a thesis in his care while I was gone, which I would not recommend. This is my favourite photo of my boys. The big one, Jack, is now 12 and a half, and he loves water polo and surfing and computers. And the little one, Tom, is now 9 and a half, and he loves swimming and bikes and eating ice cream. And he has a genetic epilepsy. Now, this is Tom when he had just turned 3. And he was my fearless, cheeky, and I thought completely ordinary, if not particularly gorgeous, child. And then one February afternoon, I'd just come home from work, and he was eating an ice cream when his head suddenly turned to the side. And he was staring at the wall, and I called his name, and he didn't respond. It was like he couldn't see me or hear me. And I thought he'd had a stroke. That lasted for a 30-minute ride to hospital. And when we arrived, he just seemed to wake up. And I was like, nothing had ever happened. We were told he'd had a suspected seizure, but not to worry, because some kids have seizures, and that we should go home and hope it didn't happen again. Now, I know that's going to be a familiar story to some people in the audience, and spoiler alert, it did. But the story I'm here today to tell you today is a story of hope. It's a story about how great doctors and parents, persistent parents, really achieved something that none of us ever expected. And although it is a story about really a journey towards precision medicine for one form of only one of the many genetic epilepsies, perhaps in the world of this great scientific innovation and medical breakthroughs we've been seeing in recent years, this could be actually a story about how the medical fraternity approaches all genetic epilepsies. And that is treating the problem at the cause and not the symptoms. But first, I'm going to unapologetically steal an allegory I heard Professor Lowenstein tell now I think it was at that stage the Dravean Genetic Epilepsy Conference in 2017. It's the same as Get Up. Okay, so then again, so a number of you may have been there, indeed many of you, and I apologise for that, but this has always stuck with me, and I really think it bears repeating. So it's a story about 2 doctors walking along a path, and they're enjoying their walk when they hear some crying out from the river. They look, and it's a child drowning in the river. One of the doctors dives in, swims to the child, pulls the child out, resuscitates them until the ambulance arrives. Then they continue their walk. Moments later, they hear another child screaming for help from the river. The same doctor dives in, swims to the child, pulls the child out. They resuscitate the child again until the ambulance arrives to take over. So a bit ruffled by this stage, they keep walking. And then again they hear frantic cries from the river. And as the same doctor goes to dive in, he sees his colleague turn and start running up the path. And he calls out, "Where are you going? I'm desperate, I'm exhausted, I need your help." And she says, "I'm going up to stop the kids falling in the river." So to the doctors and the medical students in the room, I guess I ask you to think, which doctor are you, or which doctor are you going to be? Are you in the river pulling out drowning kids every day, or are you running up that path? And for the benefit of people who don't understand precision medicine, as I never did, I think of it as this difference, the difference between pulling kids out of the river and stopping them falling in. Now, my Tom, in the face of escalating seizures, had an MRI. And the report on that MRI came back as perhaps some atrophy in the cerebellum, but otherwise normal, and repeat imaging may be warranted in 12 months. Sound reasonable? Maybe. But if my son's neurologist had accepted that advice, the story I'd be telling today would be completely different. But she didn't, because she was running up that river path to find out why he was falling in the river. She asked for a second opinion on his MRI, and a radiologist who had never met my son had seen his particular form of very rare genetic epilepsy before. And she referred him for a metabolic opinion to exclude it. And then 3 months later, in June 2016, we were told my son had late infantile Batten disease. My letters are CLN2, which Daniela did not mention before, but I knew I was the only one. Now, what's CLN2? Well, the early signs are very innocuous. My son had met the typical milestones, save that he was a terrible sleeper and he had a mild to almost becoming moderate speech delay. Now, none of that was particularly alarming. He was a second child, he had a very articulate older brother and, frankly, parents who talk too much. So we weren't worried. What I now know is that this was probably the first sign of what lay ahead for Tom. At the time he started having seizures, the kindergarten reported that he had also begun tripping over thin air. But otherwise, he looked, as you see, a pretty ordinary, happy, healthy kid. This is the story that's really told by almost every parent of a child with CLN2, or late infantile Batten disease. And what follows is, I think I can say, because the children in the audience are pretty young, it's an absolute shit show. This graph depicts it. Our children are described as falling off a cliff. So the vertical axis here is a combined ability to walk and talk. And the age on the horizontal axis is in months. So as this disease progresses, and it progresses rapidly, children lose not only the ability to walk and talk, they lose everything really. The ability to eat, they become blind, they suffer what is described as a childhood dementia, they have the very painful movement disorders, and of course, uncontrollable epilepsy before an early death. And in Australia, the average death is, or was, 8 to 9 years of age. Now, Batten disease is actually a sort of umbrella term for a group of neurodegenerative disorders, and late infantile Batten disease is only one of them. There are presently, we estimate, about 50 children living in Australia with a form of Batten disease, and there are 9 with my son's form, so the late infantile form. Now, I can still tell you exactly what was said to me when I was told that Tom had late infantile Batten disease. The metabolic doctor that was diagnosing him said, "There is no hope." And when I said, and we're talking about the child that you saw on the slide previously, it was a complete shock. And when I asked, well, what do we do next? I was told there's nothing we can do. Now, a number of people in the audience have heard me say this before. That's just not good enough. With respect, that should not be the end of the story for anybody. And it wasn't for my son. And it wasn't for my son because 7 years before he was diagnosed, a parent had refused to accept the status quo. A parent had been told, an American parent, there was nothing they could do. And that parent decided to do something. They met with researchers who had an interest in neurodegenerative conditions, and from that meeting, a drug development program was born. 7 years later, when my son was diagnosed, a clinical trial for the only and first treatment for late infantile Batten disease was underway, and had been underway for 14 months. Some of you will understand the question I asked of Deepak now, because it was underway in London, Hamburg, Rome and Ohio, and nowhere else. So, faced with that information, I wrote to the pharmaceutical company, and they wrote back. Now, I look at this letter, And I look at the date on it, and it's 2.5 weeks after Tom was first diagnosed, which just goes to show, I think, grief is an incredible motivator, or can be, I guess. And also, never tell a parent there's nothing you can do. What this company told me is they had promising results from the first 14 months of their trial. So this might actually go to Daniela's question before. There was no control group on this trial. Because of the terminal nature of this condition, it's almost treated more like, I guess, some of the cancer drugs. The phase 1 study was in patients, so not healthy volunteers, and there was no placebo. So it was actually described as a phase 1/2, and there were only 20 children on that study worldwide. But because of the promising results they were getting, they were opening or extending 20 more places at the clinical trial sites in the second or in the third quarter of 2016. Tom's neurologist put us in contact with the lead investigator of the trial in Rome, on the Italian site, obviously. And a few days later, my husband and I had the most important discussion of our life. We were crowded around a laptop with bad internet connection. And, you know, in 2016, that was before the world of Zoom and Teams and things. And we were talking to the Italian doctor. And what we wanted to know is whether this was real, whether this was something we could do for our son. We didn't want to chase rainbows across the world. And we were acutely aware that we were not able to make clear judgments in the state of mind we were in. But following that discussion, we felt that not only was this something real, it was quite significant. It was something we could do for Tom, and indeed it was the only thing. So 8 weeks after Tom was diagnosed, he was accepted onto the clinical trial extension that was occurring in Rome. And 2.5 weeks later, my family gave up our jobs and our home. We pulled my oldest son out of prep and we moved to Rome. Now, for those of you who are fans of the 2Ps in a Pod podcast, I suspect there may be some in the audience, they'll understand what I say when I tell you that sometimes people who know why I went to Italy will say to me, yeah, but it must have been great to live in Rome. And I say that is a true rectum comment. Because surprisingly, when you arrive in a foreign country in the middle of summer, it was August 2016, we arrived, so it was 40 degrees every day. And the Bambino Gesù Hospital sits at the top of a very steep hill in Rome. And as we walked up that hill, all I could think is, what the hell have I done? Now, we had a terminally ill 3-year-old, and that news was very new and very raw. We didn't speak Italian. We didn't know anybody in Italy. We had no idea how long we were going to be there for. We had no home. We had no car. We had no school for my older son. We had no medical team, no support, no therapy. And frankly, buying a bus ticket in Rome can be pretty difficult, let alone having to hand your 3-year-old over for brain surgery in a foreign hospital in a foreign language. But I would be lying if I said it was all bad. And that's because there was hope. There was hope that we had the opportunity to do something in the face of what otherwise we had been told was nothing. And I was reflecting on Deepak's comment that the further you travel for a clinical trial, the better results you should get. So I'm now going to tell you that Tom is graduating from university now at 9.5. Now, I describe this as a journey towards precision medicine because I don't think it is, well, it might depend. I'll let the scientists decide whether it actually is a precision medicine. I think of it as a precision medicine for 2 reasons. One is the type of drug it is, and the second is the way it's delivered. So the first point is Tom's mutation, for the CLN2 condition he has, affects, they know what it does. It means he does not make an enzyme in his brain. every cell of his body actually. But it's particularly acute in the brain, and that is what leads to the neurodegeneration, which leads to the uncontrollable seizures. The drug he receives is a synthetic form of that enzyme. So the absence of the enzymes means, amongst other things, he has seizures, so they give him the enzyme. The second thing about it that I think is particularly interesting is the way it's delivered. So many of us who have children with epilepsy will have children who take oral epilepsy medications. This drug is delivered directly into the brain, and that is by a port that Tom has sitting in his skull. I mentioned the brain surgery, that was to put the port in. They infuse the drug into the reservoir of the port, as you can see on the right, and it moves down through the catheter into the ventricles of the brain. Now, this infusion takes it takes 4 hours every 2 weeks. And indeed, it takes a whole day in hospital by the time you go through all the procedures. And you can just imagine how Tom loves getting this tape off his head at the end of the infusion, because obviously that needle is very delicate. It's a sterile procedure. So I think you could say, well, is it worth it? You know, what did we achieve by this mad dash across the world? This is beautiful Matilda. Matilda's mum allows me to share these photos with you to show you what this disease typically looks like by 8 years of age. And in this audience, I don't have to explain the medical issues that Matilda would have been suffering at this stage of her life. And she passed away a few months later, just after she turned 9. Now, my son has the very typical gene mutation for this condition. He had no detectable level of the enzyme, and his early stages of the disease were exactly as predicted by that graph I showed you. However, there was one difference, and that is, because of the trial we were able to get him onto, he has received treatment since he was 3 years and 10 months old. And he's now 9.5. Now, this is Tom at the same age and older than Matilda. For the purpose of this audience, one of the most relevant things might be that he has not had a significant seizure in 6 years. And that is just unheard of for children with CLN2. But interestingly, in terms of Steve talking about the outcomes and how you measure these drugs, seizures were not even an outcome that was measured on the clinical trial for Tom's drug. It was about the ability to walk and talk. Tom still talks. He has limited language, but as I left the airport at 5 a.m. this morning, he said, "Love you, mummy." And although he was up at 5 a.m, that is, I think, some of the important things. He has friends. He walks. These days, he needs a hand or a rail, but he's still mobile. He goes to school. He plays. He eats ice cream. You know, he has special needs. And yes, he takes epilepsy medications. But what this drug has done by slowing the progression of this disease, it's not a cure, but it has slowed it. It's given Tom the opportunity to have a childhood and, you know, the joy that can entail. And as a parent, it's been the difference between having a child with a very happy child with a chronic health problem, something many people deal with, in comparison to having to stand by and watch our child die painfully and suffer and not be able to do anything about it. And most importantly, after this drug was approved, both in the US by the FDA and EMA, there was quite a significant amount of advocacy that had to occur, and I'm noting the time, so I won't go into it, but please talk to me later if you want to know about that aspect of the journey. But this drug was then approved on the Life-Saving Drugs Program in March 2019. Now, the Life-Saving Drugs Program is actually the program that comes after the PBS. For rare disease drugs, they'll never get approved on the PBS because they'll never be economically efficient, which is one of the criteria for the PBS. But if you're therapeutically effective but not economically efficient, you can qualify for the Life-Saving Drugs Program, which is about extending life, and under Greg Hunt became also about extending life quality. So now there are 5 and soon to be 6 children around Australia receiving this drug. And that means there are 6 families who were not told there's no hope, and they were not told there's nothing we can do. So yes, I think it was worth it. Oh, I'm still going. Sorry, I'm still going, but I'll be quick. What I was just going to finish by saying, look, was my family lucky? Yeah, we were really lucky with that timing and the way things came together. But we weren't just lucky. It was really, a medical innovation changed Tom's life. But it was the hard work of his doctors who were running up that river path that gave him the opportunity to access it. And many of us in the room, whether we be the health specialists or the parents, will spend our days pulling our children out of that river and we'll be exhausted. And indeed, we might even be drowning in that river ourselves. But I just say, take, the opportunity to pause and consider whether sometimes running up the path is going to achieve a better result than diving in the river. Perhaps even a better result than you could ever imagine. Because it did for Tom, and I think in a world of the scientific breakthroughs, as I mentioned, perhaps this can be the story for all genetic epilepsies. And I couldn't help. I'll leave you with some resources about BDSRA, of which I happen to be the president. That's the Batten Disease Support Research Association of Australia. And what I think is blatant puppy porn. This is our Tom's dog, Sandy.